Here we are. Welcome to London, guys. Welcome to London.
Welcome, everyone. Hope you enjoyed the lunch. So I'm to speak about from Guidewire construction to the use in complex scenarios. And this needs to be an interactive session. So I need some responses from you. These are my disclosures. First question, and this is a very dangerous question. Because if you say that you know everything about wires, I have to leave. So please, answer this question, so I have an opinion on an idea of what you know about guide wires. I have enough training and understanding of guide wires. Yes, okay. Is red flag. No green flag, and I think I do yellow flags.
I think it's more likely that everyone would raise the yellow flag. I think I do, because everyone thinks he knows better than the others.
Yeah, I think I do, but again. So something about Guidewire building components. When you are choosing your Guidewire, you need to know how a wire is constructed. And essentially there's a core and there's outer external components. And the core we will discuss briefly, and also the external components. And if you have an idea on how these work, you'll have an idea of how a wire will act in a real patient. So something about core, the core material and diameter, they matter. We all know that a thick wire has more support than a thin wire. And we also know that stainless steel or Durasteel has a different property than nitinol. So the material and the diameter of which the core is made is important. The core has 3 segments. The body, the transition, and the tip. Next question. I know what a support chart is. Yes, red flag, no green flag, and I think I do the yellow flag.
Loads of green flags.
Whoa, okay. So if
speak about it then.
This is one of the most important aspects of a wire, in my opinion. Because if you can read a support chart, then you know how the wire will act. This is also a message to the companies, because who of you saw a support chart of a guide wire? By raise of hands.
A stato 20, a stato 40.
Very few.
Yeah?
Okay, very few. So if a company comes to you and says, I have a great wire, the first question you should ask them is, okay, can you show me the support chart of this wire? Because that's the first thing you want to know. Support. Support is defined as stiffness of the guide wire, providing the delivery of devices without kinking. There's a test to do this. The companies use different tests. This is the 3-point bending test. And again, the support is influenced by diameter of the core, the material, and also the grinding and the shaping of the tip. This is a support chart. And what it says is the support measured from the tip. So if you push down on the wire in each segment, you will see what the support in each segment of the wire is. And you can imagine, for instance, this wire, it has a very steep increase at around 10, meaning that the support will increase immensely. And if it increases, and the proximal segment, or the distal segment, sorry, is less supportive, then you have a certain characteristic of the wire. It will prolapse.
Okay, wait a second. So, for example, let's guess. Which guide wire, in your experience, could be this guide wire? Which would be the support chart? Maybe it's totally invented, maybe it's not, but you know, which guide wire do you think this could fit? Panelists. Theo, which guide wire do you think this could be? Command 18. Command 18?
Yeah, a little bit. There's a very dedicated wire. So,
V18,
another question.
V18 said?
V18, yes, V18. So, if you see this wire, this support chart, what will this wire do in a patient? in an occlusion, what do you think the wire will do? Will it try to stay straight or will it loop very easily? Who says looping? Yeah, okay, you're on the right track. That's good.
Sorry? Yeah.
Right. It's the Gladius MG, yeah. This is a more supportive wire, the red line, with a gradual increase in support. So this wire will not have the prolapsing tendencies this previous wire had. Short taper, long taper has to do with the gradual increase in support. If you have a short taper, this fast increase, you have a prolapsing tendency. Can be helpful if you want to purposely loop. Can also be a disadvantage if you want to navigate a steep takeoff of a collateral, for instance, for the AT, for instance. So then you would require to have a longer taper. So long tapers is better for navigating through tortuous anatomy. Something about tapers and grindings. The transition zone, so where the wire becomes thinner, is what the taper zone is. Cord tapers, what the word says, becomes smaller, and then you have the grinding, and the grinding is the segment of the tapered segment that stays the same, it has the same diameter.
So the transition from one zone to another one, am I right?
Yeah, transition from one zone to the other one. And you can also have transition-less wires that have a very parabolic decrease of the diameter, different characteristics. So if you have a very steep taper, that will mean you have a very sudden decrease of support and then thereby more prolapsing tendencies. Tip load, another characteristic of a wire you need to know and you hear a lot about. Tip load is defined as the deflection, 2 millimeter deflection of the wire when you grab the tip at 1 centimeter from the tip, fix it, push it down, and the amount of grams you need to have the tip deflected by 2 millimeters is what you call the tip load. That's the definition. Again, influenced by diameter, arterial, and the tip design, which we'll talk about a little bit later.
And Daniel, is all the, because I mean, for example, if I say I start at 20 or I connect 250, why? Is it that difference so large between a 20 and 250, or what's behind?
The 250 refers more to the penetrating power of the wire. So companies use different features. There's no wire that has 250 grams tip load. That would be, try to hold that wire. It will, it's way too heavy, of course. So, for instance, the 250T from Abbott, the T stands for taper tip, and the 250 for penetrating power. The 20 Estato means 20 gram tip load. It says nothing about the penetrating power. So, again, go to companies, explain to me what does the T mean in 250, what the 250 means. Yeah?
And also, what's your scale? Because I mean, you can't compare different brands.
No.
Say, oh, I mean, a 250 would be 10 times more rigid than a 20. It's not true. So essentially, every company has the same, and it's good to understand with the same company, different guide wires of the same company. This is what I suggest. When someone comes to promote a guide wire, to understand what is its value related to the other ones in the same company.
Yeah, always comparing apples and oranges. You know? So tip design, something about tip design. We have the transition, the tapers, and then the tip. We know about coils around the distal end of the wire. And the coils, they affect support, they affect steering, shaping abilities, they affect tactile feedback, I will show later, and of course the dimension of the wire. The tip design is very important to have this tactile feedback. Two main designs is the core to tip design, which is the above one, in which the core is linked to the tip, and you can imagine that this tip has good feedback. If you push the wire, you will feel hopefully the same thing happening at the tip. So if you push the tip on the plaque, you will feel it in your other hand. So this one feature, very good tactile feedback, better steerability, and it is a durable tip. So this kind of design will have a tip that is more durable than, for instance, the shaped ribbon, which is the below design. The shaping ribbon has advantage that it is shapeable, it's more flexible, but it's a very delicate tip. So in CTOs you will never see a shaped ribbon because that makes no sense. Then we come to penetrating power, tip shape and penetrating power. It's very simple. If you have a tip load of 12 grams and the tip diameter is 0.18, you have a good penetrating power, for instance, 47. If you have the same tip load, but you will decrease the diameter of the tip, you will have an increase of the penetrating power. So tip lobe is correlated to penetrating power, but also the tip diameter is correlated to this. This is enlarged again, and by the way, penetrating power is defined as grams per square inch. So smaller diameter of the tip means higher penetrating power.
Because you apply the same power to a smaller place. So essentially you transmit all this power, am I right? So
Yeah, it's like walking on snow with snow shoes or high heels. Yeah.
who doesn't do with high heels? Yeah.
I don't know. Something about the coils around the tip. I think important to remember is that if you have a long segment coils, these wires are typically more flexible. If you have a very short segment with coils, these wires are typically more supportive. So, next question. Which of these three wires has the highest penetrating power? And above we have an 14 workhorse guide wire, long coil length in between, 014 short coil length, and then we have the 018 workhorse guide wire, again with a short coil.
Guys, this is, if you listen carefully, you know what to answer. Let's see.
So who goes for green?
Very good. So why? Why you don't go for green?
Nobody goes for green.
Why?
Okay. So
let's start from yellow.
Okay.
Who's going to go for yellow?
Okay, only a few. So why yellow?
Why yellow? Correct.
Well, I clearly wasn't listening properly. But my feeling was it's a short coil length. 018, you get more power behind it, even though the red might have better characteristics. You get more bang for your buck with the 18. But tell me I'm wrong.
What about walking on the snow? Am I right? Is it correlated to walking on the snow?
Yeah.
Okay. So essentially, he said something right. I think he said something right and something wrong. If I try to put
You're the
myself on
moderator.
spot,
Yes.
okay? I didn't know that before. Short, let's give my solution. Short tip, more penetration. Smaller diameter, increase of penetration. Am I right? So I would choose personally the green one with the short tip and 014. Am I right?
Yep. Yeah, that's right. So it's important to realize that if you need a higher penetrating power, you will need to go for lower profile wire.
I learned it today. Yeah? I learned it today from what you said. Thank you so much.
It's like sticking a thick needle in a tough skin or very, very like dry needling needle. That's the difference. So that's about penetrating power. But if you talk about support, then you would be correct because the yellow one would have the highest support.
But the coil length doesn't play any role.
The coil length has a role in the support. So the shorter the coil length, the higher support. Like in this one. Are you still with me?
So just a comment?
So, for example, the Amplatz 013.5 has a short tip, has a more support. With the longest, you have less support, yes.
Yep.
Even for the bigger wire.
At the same time, you're more likely to penetrate and to perforate a renal artery if you go there with a 1 centimeter compared to the 7 centimeters. So yeah, that's exactly. This is what, like, there's no like the perfect wire. The perfect wire is for the perfect indication.
Yeah. So,
yes, question.
What, if you said like the shorter the tip, it's more like you have more support. Why isn't the red the one with most penetrating power?
Because of diameter.
no, so short tip, short coiling so short coils around the wire,
Is higher
is
support.
high support. So if you have a wire with short coils and O14, it's very high penetrating power.
So it's the red one, the most penetrating.
No, because that's a long coil. It's a long.
Oh, sorry, you're correct. No, sorry, you're correct. You're awake. No.
Oh, okay.
Because the top one was the long coil.
The long coil. You see?
No, you're totally correct.
Finally, fun one. Okay, it's correct.
Because we thought, okay, Lorenzo,
Yeah. Please explain. It's a game, guys. It's interesting because going through errors, we learn. And thank you so much for highlighting. Theo, what did you say?
the same thing.
That was Theo said.
Say. Take your microphone.
I mean, the first one has long coils, and this is the problem. So you need
Yep.
short one
Yep.
in order to have also penetration. Is
Yep.
that right?
Yeah.
You know
Yeah.
what? I was biased by I said right, but I didn't say. I thought that the length of the blue stuff.
The length of the blue stuff, yeah.
Was the length of the.
Oh, no. So,
Yes,
yeah, I can go. No, but you're completely right. Short coiling segment on the tip means high support.
Now,
So therefore,
now we are completely confused. Can you put now the right solution and explain why?
so it's the red flag.
Perfect.
Red flag,
Why?
smallest diameter wire, and it has a short coil.
Perfect.
That's it. So you were the only one, oh no, with Theo, who was awake.
Yeah.
But, he's the master, so I expect.
Okay, well this slide got mixed up a little bit. It's about lubricity, coils and covers. Around the coils of a wire, coatings and covers. Around the tip of a wire, around the coils, you can put a coating or you can put a cover. And essentially, the more hydrophilic a coating is, the more lubricity there is, so the more easy it slides through CTOs or microchannels. But it comes at the expense of tactile feedback. If you have a very, very smooth passing of the wire, you can imagine that the tactile feedback will be less. So workhorse guide wires will typically have a hydrophilic coating, and the CTO guide wires, at least at the tip, they are non-coated. Again, hydrophilic coating makes passage of a wire through an occlusion or a microchannel very easy. What's the use of using a sleeve or a jacket around the tip of the wire? Both are hydrophilic coated, but if you use a sleeve, or another company will call it a jacket, you will have a smoothing of the tip of the wire. So the coils, they will create an irregular aspect and thereby causing friction. Also, if you have a hydrophilic coating on these coils, but if you put a jacket on top of the wire, which is also hydrophilic coated, you will smoothen out the coil, the surface, while you have the hydrophilic properties. So these guides, the workhorse guide wires, which we use to navigate through tortuous anatomy, to search for microchannels in CTOs, they will have a sleeve or cover with hydrophilic coating.
May I ask you something?
Yeah.
Can you go back? So the advantage wire, where does it belong? To the first one? To the first group?
Yeah. The advantage from
14,
Trimo.
14, yeah.
Yeah.
Okay.
And there's hydrophobic coating, all right? Are you talking about this later, or do you want to?
No, I'm not talking about hydrophobic coating. No. You want to talk about this?
Can be hydrophobic coating. Like it's like if you want to have a really good penetration, like a CTO wire, you need the hydrophobic coating not to slide everywhere. So the more you want the guide wire to penetrate, the more you have the hydrophobic coating.
Yeah.
Okay. Usually we are used to hydrophilic coating because we want to navigate. If you want something to penetrate, it's going to be hydrophobic.
Yeah. So and now there are most CTO wires have because if you want to penetrate a proximal cap right at the level where you have the collateral coming off, you don't want the wire to slip again and again into the collateral. You want to as you say, Lorenzo, the tip of the wire needs to grab the proximal plaque. And that you can do by removing the hydrophilic coat on the tip of a wire. But once the tip of the wire is in the occlusion, you want the next segment to be hydrophilic again. So you can penetrate the cap of the wire but afterwards you will have the hydrophilic aspect of the wire, which makes smooth passage possible. So let's say the new CTO wires, they will have this hybrid configuration with a non-coated hydrophilic tip, hydrophobic tip, and a hydrophilic segment behind it. So
Daniel, is this these are halberds?
Yeah. Yeah, the halberd, for instance. Yeah. So from guidewire construction to use in complex cases, I have a few examples. The way I do it, but the next talk will, I think, also discuss this a little bit. We look at the lesion characteristics. Where is the lesion? Is it a lot of calcium, no calcium, above the knee, below the ankle? You will then kind of decide in your head what kind of wire you use, and the type of wire you want to choose is kind of based on what we just discussed in the yellow segment, and then you will select your guide wire. This is kind of how it works. I will show you a video, and then I would like you to tell me what kind of wire this is. So no brand name, but just what kind of, so we have CTO wires, we have workhorse guide wires, we have, well, hydrophilic, hydrophobic.
Look at the color also. The color is helping you in a way, yeah? Oh gosh, you can't go through the occlusion.
So it's a little bit of calcium at the distal AT, also the pedal artery, and I thought, well, I can try to do this with this wire. Yeah. Maybe I'm wrong, maybe I'm right, I don't know. So who wants to comment on this?
Here we are. Coming, microphone is coming.
Gladius MG.
Sorry?
Gladius MG.
No, this is not the Gladius MG. Could be. Why?
Because it was starting to prolapse.
Yeah. So at some point during this maneuver, yeah. Let me run it again.
I think it could be advantage 014.
No. And why not?
Why not?
Because I think you need a lot of support, and you need to go very short tip in order to engage the microchannel in this patient. I think these guide wire have too long tip for this kind of problem, because you lose the ability to have tactile feedback in your hand.
Mm-hmm.
And exactly, that's why I said be careful with the color, because the color is telling you that the hydrophilic coating is a long tip.
I will tell you what wire this is in a moment.
Last one. Let's try.
Can I just ask a question? Have you played with the wire? Have you done anything to the tip before you put it in the patient?
No.
I thought it might be a command 14.
No. This is, shall I tell you?
Is it a halberd?
No.
Come on, Daniel.
This is the normal 014 Gladius,
okay.
which is my workhorse guide wire. I didn't show you, but on top there were subtotal stenosis, and so I needed a wire, and there was not much calcium. There's a little bit of calcium, not much. So I needed a wire that would be able to navigate through tight stenosis, and then maybe also with the right support could tackle a distal AT occlusion. And what you see here is this gradual support. You see a little bit of prolapsing here, but the tip shape is kind of okay. And then by giving more support, also with this 014 Gladius, it's possible to navigate through these occlusions.
Of course, on the top of what we said before for the penetration, if you support with a catheter, you increase enormously the penetration power. So it's not just the
Daniel,
wire.
a short question, because actually someone could say that this was not the right wire for this lesion.
I agree.
So my question is, where is it worth spending money? On the wire or on the support catheter?
That's a good question. I don't know. I'm a Dutch guy, so I should know everything about euros. I don't know. I don't know what my workhorse guide wire costs and what, for instance, CSI or a balloon as a support would cost.
This support catheter that you're using is just normal 035.
Navicross.
Navicross. So the point is, actually, what we learned from today is that it is worth trying on changing wires and using a classical support catheter, because the wire will go through if it is a dedicated one.
Yep. What wire would you primarily choose to
I
do
cannot
this?
see the lesion. It was a stenotic or a CT?
No, so there's a CTO. So on top you have tight stenosis, and this was just a CTO, just a typical distal AT with the calcium into the dorsalis pedis.
You know, we have learned a lot today from wires, but still you're going to your cath lab and you will start with your
Okay,
glucose wire.
let me rephrase. Would you do a whole procedure with the CTO wire?
No.
No, okay. So ask me how many wires I've used in this case. One, only this one.
Yeah.
Alternatively,
Yeah,
I would do.
One moment. I totally agree with Theo because you can work with this guide wire also only if you support with your catheter the tip of the guide wire up to 1 or 2 centimeters, not more, but not in every case. It is possible to advance your guiding your catheter up to the occlusion.
I totally agree.
I totally agree. It is better to change the guide wire. Sometimes that use 3 or 4 different.
I agree with you, but I disagree with you on this case. Why? This is AT. Tell me which balloon as a support catheter you can enter the AT without shaping the wire.
Yeah, but also tell me how many ATs don't have a stump. Where to go?
No. Of course. But in my opinion, but there are many ways to Rome, right? My opinion, if I use a dedicated wire to navigate through stenosis and occlusions, I do not want to touch the shape of the wire. So, meaning I will either use a Berenstein catheter to go into the AT, or in this case, Navicross. Why a Navicross? Because it's more expensive than a Berenstein, obviously. This is hydrophilic coating. So knowing that I have to cross.
The support which gives you, it's amazing.
And it's
braided catheter.
And you can do, I'm a fan of using 035 catheters because I can do parallel wiring, if not possible. Go retrograde. It's easy to get a pickup in the catheter. It's much more difficult with 018 or dedicated, so a smaller support. So, but that's my preference. It's not, let's say, the only way, obviously.
Okay, let's go on. Let's go on.
Well, let's.
If you don't advance your catheter, you need to remove the catheter, advance balloon, predilate, remove the balloon, and re-advance the catheter. And so I think that at the end of the game, it is better in this case to follow your guide wire with the balloon.
Also, just to cut this, because if not, we're almost running out of time. The important thing is to be flexible in your mind. You can change the catheter, you can change the guide wire. We can discuss here till 3 in the night. But the important thing is something doesn't work, and essentially you was going intraluminal. If that wouldn't work, probably you would have changed the guide wire at that stage. So the important thing, and I want this to pass to you, you have different devices, catheters and guide wires. You need to know all of them, the characteristics as he went at the beginning, and to switch approach very easily if you think that you're not convinced from what you're doing, isn't it?
Yeah, I agree. So back to the support chart. Which support chart is this wire? Red?
No.
Red flag?
Black. I want to see a lot of green flags here, am I right?
Oh, no, Lorenzo.
That's good, perfect. Okay, the red flags, guys.
Red flags, because this wire, after maneuvering a lot, it had a little bit of prolapsing tendency, but after only so many millimeters. And let's say the MG would have looped immediately. Okay. So gradual support. Okay. Then one case, to wrap this up, 46-year-old male, diabetic patient, poorly regulated, partially blind, EGFR 43, gangrene of the right big toe, and 3 failed attempts elsewhere to open up the posterior tibial.
Wait a second, I also want to comment on imaging. How many people use CO2 for cases like this, with a single, almost single vessel runoff in the BTK? Okay, you want to comment on that?
Yeah, so I've switched to CO2, I think about 90% of my cases. It's not because all the patients really need CO2, but in my experience, if you do need CO2, you need to have the experience to use it. And we see more and more patients with renal failure. And with that respect, if you really need it, you need to know how to perform the imaging. And that's why I always start with CO2. And if I'm not confident with the imaging quality, I will switch to contrast if possible.
Can I ask you your protocol for injection? Because you know some of the pain.
Yeah, good question. I think 80–90% of my cases are with popliteal blocks because of the the high ballooning we do, the difficult recanalizations. So I think a lot of, and when you give popliteal anesthesia,
Daniel, do you put your own blocks in, Daniel, or do you have do you block yourself? Or?
Yeah. That's a whole different talk, but yes, I give popliteal anesthesia myself. It's super easy, fast, lidocaine, so it works for 4 to 6 hours. So daycare is also possible. A lot of advantages of using popliteal blocks.
Yeah, very briefly, just to say that with automated CO2, it is, I think, painless in most cases. And it might sound weird, but in the CTOs, I find that you actually see the microchannels a bit better.
Correct, yeah. So CO2 has no viscosity. So you see a lot more. You see also more bleedings. Every now and then I use it in a GE bleed. You will see CO2 imaging much better. These are these are the images as I get them on the angio table. So I have not processed these. This is what you get. So if you process these, you have even better imaging, and you can stack them and have the cool imaging. So in this case, you needed to open up the posterior tip, and this is what I was talking a little bit about. And this is why the last wire is not advantage 14. So to navigate in BTK arteries, what would be, in your opinion, be the best tip shape? A or B? A is the green flag, B is the red flag.
Oh, green. Really?
Cool, yeah. I would prefer the red flag as well.
But navigate, you mean BTK arteries which are patent or which are occluded?
Either way. I will show you.
Okay.
So navigate in, not into, but in.
Okay.
Yeah, this is different. This is me coming down with the PT2 wire. And as I said, this is a very cheap wire, 50 euros. I'm not afraid to use this wire to navigate into the artery. So in this case, I did not use a 035 support catheter. I just used a wire to enter the tibial, the positibial. And you can see that this tip shape will cause you to enter every collateral that's there.
The vessel is patent, guys. This vessel is patent.
Yeah.
Okay, just to clarify, PT2 only for vessels which are completely patent. It will never penetrate anything. The moment you push, it will destroy, and you won't use it again. Yeah.
So for me, type A would be the wire to navigate into the artery, and type B would be the vessel navigating in the artery itself or in the occlusion, right? So I went down with my PT2. This is a 1.5 Armada XT balloon. And I've reshaped, at that time, the PT2 wire from this curved to an angle. Try to navigate, but as Lorenzo says, this is not a CTO wire. So I remove it immediately, right? This won't work. Don't try for 10 minutes, it just won't work. The PT2 will probably lose its tip in this vessel. So what would the escalation be? Antegrade, workhorse guide wire or higher tip load, CTO wire or retrograde. I've tried antegrade CTO guide wire. This is the 014 Halbert. It failed from antegrade. Also with dorsiflexion of the foot straightening the vessel, I went out and out and out again, probably because also the previous recanalizations attempt. And therefore I decided to go retrograde. Next question, and this is an open question for you guys. What kind of retrograde wire would you use? Who wants to comment? There's no wrong or right answer.
I will do
here.
a little comment. Always be sure to puncture quite lower compared to the occlusion, because no matter which wire you use, if you puncture, this is quite a deep puncture, always start quite proximal, because if you don't have a stump, no guide wire will work, and it will lose your access in no time, and you won't be able to insert a microcatheter. Conrad.
Once I punctured with the, I normally use the radial arterial needle and just the steel wire that comes with it, because if I need to pull it back, I don't want to shear off a hydrophilic coating. But if I'm very sure I'm in, I will just put a 300 wire in, whatever it is.
18 or 14?
18, because I'm going to snare it and I'm going to reverse it.
Red 018, red.
Red 018, green 014. Yeah, I mean, yeah, many 018. And so
Yellow, who never performs a retrograde puncture.
So,
Daniel, can I just challenge on something? So, I do very much the same. I've just added in another step. If I come to a distal CTO and then I'm out with Vestal with the halberd, I'm giving it one more go now with the Gladius MG and letting it prolapse and seeing if that softer tip will just keep me luminal, just because to try and stay antegrade. Is that something you would try yourself, or are you giving it one go and having a lower threshold for going retrograde?
This vessel is very calcified, and it's obviously tortuous. Yeah, you could give it an attempt, but in my experience, quite often you go subintimal, and then you might ruin the plantar, or even if there's a heel wound, some collaterals coming off. So I try to really stay to intraluminal on this. So my next step was retrograde puncture. Yeah.
Can we just elaborate a little bit more the selection of 014 or 018 for retrograde?
Yeah.
Because for those who are using the 014, the main advantage of using an 018 is that you have a lot more support. And as Lorenzo has mentioned, if your occlusion is quite close to your puncture side, and if you are not able to progress and you need a support catheter, the chances as to dislodge the wire are higher if you're using an 014.
Yeah.
So we strongly recommend you to use an 018.
Yeah.
And then you can switch to 014 if you want, like a Proceed, for example, if you are engaged. So essentially, if you have a microcatheter, which is a sort of sheath, then you can change. But the first move, I personally do on an 018 in order to have as much stability as possible.
And with a short floppy end.
Absolutely, yes.
Yeah, for me this was the 018 halberd. In my opinion, the ideal retrograde wire is not out there yet. So I have to do what's available. And in the beginning, I used the V18 and cut the tip to get the optimal support. I switched now to the 018 halberd, which has a very nice support. It has a uncoated tip, so you can really grab on the plaque, and therefore it has less tendency also to loop and go subintimal in this segment. Because if you go subintimal here with the calcium, the chances that you have a good lumen after dilatation are not that high. So try to really stay intraluminal. Yeah, so this is the 018 halberd, a 7 centimeter micro puncture needle. And the prolapsing, as you mentioned, August, you see that almost happening here as well. If I push a little bit harder, the wire will go out. So that's why you will need the highest support wire possible in an 018 platform. But gently, pointing the needle in the right direction, preventing this prolapsing outside the artery, and by torquing the wire, I was able to connect up to this level. Went down with my 1.5 Armada balloon, and we performed essentially a reversed cart. Then wired with the 018, with the needle still in, so no sheath at this point, with the needle still in, wired higher up. Then I was able to use the kissing wire technique, so the wires tend to find each other and go anterograde with the wire into the lateral parental artery. And by doing this, I could finish the procedure. This was the pre-image, post-image, and this is the AP view of the foot.
One thing I would suggest is, like, guys, try to support. It's super good, so it's like super God, but try to support you by, also the access was in a very diseased and small vessel, but try to support you with the microcatheter. The microcatheter will make your life so much easier, because the moment you push, you perforate. I mean, I think the microcatheter is a great tool in these kind of cases. If you do retrograde puncture this way, you know what you're doing, but always remember the microcatheter, which helps you. Conrad?
I completely agree, but I think the worry is that things might look like a CTO, but they might actually be a microchannel there. And I think the point that Thanos made about CO2 and microchannels is excellent. So if you plan to barge your way through because you've decided it's fully blocked, then I think you might not give a chance to find a microchannel. So it's finding that balance early, and therefore starting every BTK case with a 14 wire, I think is a good idea. And that's what you were doing, right? With the curved wire, the P2, you were trying to give it a go, and that was fine.
Yep.
And although you knew it was a CTO, you never really know it's a CTO until you try. And I think that's only experience, right?
Yeah,
But,
correct.
I think your escalation is really an excellent point, and thank you.
Let's go with the take-home message, because we're very run out of time.
Sorry. So, two simple ones, right? You need to know about guide wires, because then you can select your guide wire, which is maybe different from you, Lorenzo, and mine. But another thing is look at support charts and ask the industry to show them the support charts. Because every time, in my experience, when you have someone presenting you with a new wire, all you can hear is, this is a very cool wire, it's hydrophilic, it has a very good coating. But when I ask them, okay, show me the support chart so I know what the possibilities are, you won't get them. So ask for them. Thank you very much.
Our third take-home message, of course, is that Lorenzo skis in high-heel stilettos as well. That's one of my other take-home messages in this talk. Thank you, Lorenzo.
No, it was easy. Like, I just repeated it. I usually repeat what people say. That's why sometimes...
Anyone else is getting an image of you in stilettos skiing.
It's a cheap way to learn. Thank you so much, Daniel, for this, and thank you so much.